Okay, so now we're going to be looking at Chapter 4. It's covering medical, legal, and ethical issues. The National EMS Education Standard uses simple knowledge of the EMS system, safety, well-being of the EMR, and medical legal issues at the scene of an emergency while awaiting a higher level of care to arrive. We will be covering consent and refusal of care, confidentiality, advanced directives, tort and criminal actions, evidence preservation, statutory responsibilities, mandatory reporting, ethical principles and moral obligations, as well as end-of-life issues. EMRs need to know some basic legal principles that guide how they provide care to patients. Knowing these principles can help EMRs provide the best possible care, and the laws differ from one location to another. So EMR should learn the specific laws to the region, state, province, and sometimes even counties that they are working in. Things to not lose sight of: above all else, we do no harm. Provide all your care in good faith, keeping the patient's best interest uppermost in your mind, and provide proper, consistent care. Be compassionate and maintain your composure. Okay, so let's talk about the duty to act. When you are employed with an agency or volunteer with an agency and you are dispatched to a call and you are responding to that call, it is your duty to act when you arrive on scene or respond, whether it be for an illness or an accident or something of that nature. You must proceed quickly to the scene as dispatched, provide the emergency medical care within the limits of your training and the equipment that you have on hand. Failure to respond to or render necessary emergency care leaves you and the agency that you volunteer with or are employed with open to legal action. The standard of care. As an EMR, you are expected to use the knowledge and skills to the best of your ability under the right circumstances, or under the circumstances you are in. The standard of care is the manner in which you must behave or act. To comply with the standard of care, you must meet two criteria: treat the patient to the best of your abilities, and provide care that a reasonable, prudent person with similar training would do. It is important to know the local standards of care and what statutes affect your community. Scope of care is defined by the U.S. Department of Transportation's Emergency Medical Responder Education Standards. These standards specify the skills taught in this course and the way that those skills should be performed. State scope of cares may modify parts of these specifications in education standards. Medical protocols or standing orders are based regional or state, and online medical direction. Ethical responsibilities and competence. The community expects you to conform to the established codes of what is right and wrong. Treating a patient ethically means doing so in a manner that conforms to the accepted professional standards of conduct. So we need to stay up to date on what EMR skills and knowledge are required of us. Review your performance and assess your techniques. Peer review is a big useful tool. Evaluate your response times. Try to follow up patient care outcomes with your medical director or hospital personnel. Take continuing education classes and refresher courses. Most agencies mandate that you have a certain amount of hours per their department. Always provide complete, correct reports to other EMS providers, and never change a report except to correct an error. And when you're doing your reports, try to document as objectively as possible. Try to leave your personal opinion out of your reports. Consent to treat. Consent simply means giving approval or permission. I'm an EMR, an EMT, advanced EMT, or a paramedic, and I arrive on scene and I say, "May I help you?" You tell me, "Yes, please." That's consent. Legally, several types of consent exists. In express consent, like I just demonstrated, the patient actually lets you know verbally or even non-verbally, sometimes with a head shake, or they'll motion to you that they are willing to accept the treatment. Express consent is based on the assumption that the patient has the right to determine what will be done to his or her body. They should also be informed of what you are about to do. We don't like to walk up and just grab somebody and start doing a blood pressure or putting a tourniquet on them, things like that. We want to let them know what's going on. Sometimes this is called actual consent. The patient must be of legal age and able to make rational decisions for themselves. We'll be discussing emancipated minors. That is defined in your state law, so it varies from state to state. Any patient who does not specifically refuse emergency care can be treated under the principle of implied consent. You should never hesitate or treat an you should never hesitate to treat an unconscious patient. Someone who is unconscious, they cannot answer yes or no whether or not they want your help, so that is considered implied consent. Consent for minors. A minor is a person who has not yet reached the legal age, usually 18, designated by a particular state. Here in North Carolina, it is 18. Under the law, minors are not considered capable of speaking for themselves, even though they do have their own voice, and we like to let them express it. Emergency treatment of a minor by a physician must wait until a parent or a legal guardian consents to that treatment. If permission cannot be obtained, do not hesitate to give that appropriate emergency care. That would fall under the implied consent as well. Never delay or withhold that emergency care treatment from a patient who is a minor. Of course, there are certain skills and tactics to help facilitate that care, especially in uncomfortable situations where a minor might be afraid of us. So using tact will go a long way with minors. Consent for patients with a mental illness. Legal issues are more complicated if the patient who refused to be treated appears to be out of touch with reality. If a person appears to be a threat to their self or others, place this person under medical care. You know your state's legal mechanisms for handling these patients, and do not hesitate to involve law enforcement agencies. A lot of times, just having the simple presence of having law enforcement on scene with someone who you perceive might become difficult or combative or argumentative can help diffuse that situation. Of course, on the other hand, sometimes law enforcement presence will escalate. So it's really a case-by-case. Use your judgment when you're dealing with those decisions. Patient refusal of care. A competent adult has the legal right to refuse care or treatment. You can continue to talk to the person who has refused care and try to help him or her understand the consequences of refusing. In fact, you should always try to tell them that what the consequences might be of refusing. And you'll want to explain the treatment, the reason that the treatment is needed, the potential risks if the treatment is not provided, any alternative treatments that might help. Taking that into consideration, we don't want to advise people on medical things that are outside of our scope as well. So we want to be careful when we start having that conversation. Patient refusals should be documented on your patient care report according to your agency's protocols. Refusals are typically, they need better documentation and more detailed documentation. Again, keeping it as objective as possible. And we're going to talk about advanced directives. An advanced directive is a document that specifies what a person would like to be done if he or she becomes unable to make decisions or medical decisions for themselves. There are three types of advanced directives. There's a living will, which is a written document drawn up by a patient, a physician, and a lawyer, and it states the types of medical care the person wants to be done or withheld if he or she is unable to make those treatment decisions. It's often written when a patient has a terminal illness, such as advanced cancer. A durable power of attorney for health care. This allows a patient to designate somebody else, oftentimes a spouse or another loved one in their family, to make medical decisions for them in the event that they are incapacitated or unable to make sound decisions. They may refer to that representative as the patient's healthcare agent or healthcare proxy. And then thirdly, we have the do not resuscitate or a DNR order. It is a written request giving permission to medical personnel to withhold resuscitation in the event of cardiac arrest. Most frequently used for patients who are in hospitals or nursing homes or have terminal conditions. One thing to remember when talking about DNRs that do not resuscitate, and with cardiac arrest, it means when the heart has stopped, that's when it applies. If they still have a heartbeat but they're not breathing, doesn't apply. If they're circling the drain and they're going downhill, that DNR does not apply until the heart has stopped beating. Always remember that. Okay, here you see an example of a do not resuscitate order. There's a couple things to keep in mind and pay attention to with DNRs. So you see at the top there's the effective date, which always has to be filled out. There is also the expiration date, if any. Very rarely will these actually be filled out because once you have a DNR, it's pretty much a terminal illness or a end of life expectancy. So this checkbox here that you see should be marked if there is no expiration. You need the patient's full name. That varies from person to person. Some people have middle names, some people don't. Some people have multiple names. So that's what should be on their legal identification. Should mimic or copy that. And then down here you have the signature of the attending physician or physician assistant or nurse practitioner. Those are the three individuals who can validate a DNR. And their name should be printed. They should have the address, the city, state, and the zip code of their office, not their home address. And then there should also be at least one telephone number down here where that person can be contacted or their office can be contacted. Here we have an example of a MOST form. This usually accompanies a DNR. Sometimes it doesn't, but usually it is more specific details as when the patient is nearing the end of their life or they're incapacitated, specific treatments that they either want to be withheld or they actually do want. So for example, down here in section D, this would be where they would check whether or not they want IV fluids long-term, if indicated, IV fluids for a defined period, trial period, feeding tubes, or no feeding tube, or no IV. So those would be specifically checked. Now for an EMR, that doesn't really matter for how you're going to treat the patient, but it is something important that you might want to pass along to a higher medical care team, such as advanced EMTs or paramedics, or even the EMTs, or if you're handing them directly off at the hospital to a doctor. They'll also appear in section B. There's a section for full scope of treatment. That one, if you have a DNR with a MOST and it says full scope of treatment, that might be something that you or your partner need to call a hospital real quick, call the ED and get some online orders of what to do, because now you have two legal documents that are conflicting each other. One says do not resuscitate, the other one says do. Also, in talking about DNRs and MOST forms, you have to have them in hand. They need to be the original copy, which is usually a golden yellow color as you see here in the slide, or a certified copy of the original. And that one usually has a stamp or a notary on it certifying that it is a copy of the original. We can't have pictures, we can't have Xerox copies, we can't we can't honor digital copies, anything like that. And especially even if they're not filled out completely, we can't honor that. and we have to have it in hand in person. Now, if a family member were to remove that DNR from the scene, that's kind of a case-by-case basis, whether or not it's still valid. So that's individual discretion at that point. Okay, so abandonment. Abandonment occurs when a trained medical professional begins emergency care and then leaves the patient before another trained person arrives or is able to take over. Once you have started the treatment, you must continue that treatment until the person who has at least the same level of training or higher has arrived to take over. Now, that's not to say that in dangerous situations, life over death, that you must stay and die with that patient of yours. We still all need to go home at the end of the day, and if it's a situation where it is imminent, then that's not really considered abandonment at that point. But if, just to sit there and get up and walk away from a patient and say, I'm done with you, that is 100% abandonment. People dead at the scene, or DOAs as we call them, dead on arrival. If you see any signs that the person is alive, you should begin providing care. You cannot assume a person is dead unless one of these conditions exists, or these are also known as signs incompatible with life. So decapitation, rigor mortis, tissue decomposition, their body has started to decompose. Dependent lividity, that is where all the blood begins pooling down at the lowest part of the body, and it usually looks like a really, really bad, large bruise, and you can tell it's just all the blood is pooling at the bottom. If any signs of death are present, consider the patient to be dead. It is important that you know the protocol to your the protocol your department uses in dealing with patients who are dead at the scene. What's the next step? Who am I calling? What other resources do I need? Law enforcement? Do I need a medical examiner, a coroner, what have you? If you're uncertain, if it looks bad and it looks like it could be injuries incompatible with life, but you're not 100% sure, you still need to check for a pulse. Oftentimes, pulses may be very low or very weak and hard to discern. So you really have to pay special attention in those situations. Give them a few extra seconds in your assessment. And negligence. Negligence occurs when a patient sustains further injury or harm because the care administered did not meet the standard of care. For negligence to occur, there are 4 conditions that must be present. Duty to act, breach of duty, resulting injuries, or proximate cause. And confidentiality. Most patient information is confidential. We don't go sharing it with our partners who are not on that call, or telling our friends or neighbors, including their history, your assessment findings, your treatment provided, as well as your communication with the patient, things that the patient said or did, things like that. Information should be shared only with other medical personnel who are directly involved in the patient's care. In certain situations, you may release confidential information to designated individuals. Typically, agencies have officers that are designated for that. Some information about patient's care may be classified as public information, including the patient's name, address, age, and the hospital to which he or she was transported to. Health Insurance Portability and Accountability Act of 1996, otherwise known as HIPAA. HIPAA had many aims, including improving portability and continuity of health insurance coverage and combating waste and fraud in health insurance and in the provision of health care. The section of the Act that most affects EMS relates to patient privacy. The aim of this section is to strengthen laws for the protection of the privacy of the healthcare information and to safeguard the patient's confidentiality. HIPAA provides guidance on what type of information is protected, the responsibility of the healthcare providers regarding that protection, and the penalties for breaching that protection. And Good Samaritan laws. Good Samaritan laws protect citizens from liability for errors or omissions in giving good faith emergency care. These laws vary considerably from state to state. Legal experts have noted that Good Samaritan laws may no longer be needed. These laws provide little to no legal protection for an EMS provider. Often EMS provider levels are addressed in other sections of the state's public health and education law. Basically, once you've received professional training, you no longer fall under the Good Samaritan Protection Act or law. You should become familiar with federal, state, and local and agency regulations that affect your job. Certification and registration may be required to work as an EMR. And you are always responsible for keeping certifications and registrations current. They are your own responsibility, not the agency's, not your institute, but yours. So reportable conditions or reportable events. You need to learn the crimes that are reportable in your area. Know your agency's procedures for reporting these crimes. Failure to properly notify authorities of a reportable event may result in penalties against you or your agency. Things like knife wounds, gunshot wounds, motor vehicle accidents, suspected child or elderly abuse, domestic violence, dog bites, and rape are all reportable events. If you have seen one of these happen or you suspect it, it should be reported. No one's going to fault you for reporting something that you think may have happened, and then once the investigation is complete and it comes back as it didn't happen, no one's going to fault you for at least being proactive. Many emergency medical situations also are crime scenes, so you keep these considerations in mind. You want to protect yourself. We all go home at the end of the day. Be sure the scene is safe before you try to enter. If the scene becomes unsafe while you're there, retreat or get to safety. If it is unsafe, wait before you arrive. Wait in a safe location until law enforcement has cleared the scene and made it safe to enter. Your first priority is patient care. Nothing except your personal safety should interfere with that effort. That kind of goes back to the patient abandonment that we just discussed a moment ago. If it is life over limb and it is affecting your safety, that kind of protects you from the abandonment. When you are assessing the scene, document anything that you see that seems unusual and move the patient only if necessary. If you must move a patient, take a mental snapshot of the scene, touch only what you need to touch to gain access to the patient. Preserve the crime scene for further investigation. Be careful not to cut through knife or bullet holes in the patient's clothing. So typically if you have to cut to the side or cut around it to try to keep that intact. Be careful when you place equipment or where you place equipment to avoid changing or destroying evidence. A lot of times in some crime scenes there'll be pools of blood. We want to avoid walking through that blood or setting our equipment down in that blood. We also want to be careful not to disturb anything on countertops, tables, or moving furniture around unless it's absolutely necessary to provide adequate patient care. After you have attended to the patient at a crime scene, consider writing a short report about the incident as soon as possible while the memory is still fresh in your mind. If you can, make a sketch of the scene that shows how and where you found the patient. Sometimes that helps. Documentation should be done according to the policies of your organization. Policies should follow appropriate state and local laws. Your documentation is the initial account describing the patient's condition and the care administered. It serves as a legal record of your treatment, provides a basis for evaluating the quality of patient care provided, and should be clear, concise, accurate, and readable. Most reporting systems nowadays are done on mobile tablets or on computers. So you're typing those, but using proper grammar and punctuation is important as well. Remember, when you're documenting, if you leave something out and it's not documented, it didn't happen. And if it comes back that something did happen, but it's not documented, that raises a whole bunch of other issues and questions. Your documentation should include the condition that your patient was found in, a description or the nature of their illness or injury, patient's initial vital signs, and then the repeat vital signs, and your ongoing assessments, treatment that you gave to the patient, or your interventions, the agencies or personnel who took over treatment of the patient. A lot of times, simply saying thus and such county EMS unit, whatever, or thus and such fire department was there. You don't actually have to have their specific personnel names. And then, of course, any reportable conditions that are present, any infectious disease exposure, bloodborne pathogens, or body secretions, things like that, and anything unusual regarding that situation. Okay, so as an EMR, you have the duty to act when you are dispatched on a medical call as part of your official duties. You should understand differences between express consent, implied consent, consent for minors, consent of patients with mental illness, and the right to refuse. Advanced directives give a patient the right to have care withheld. You should understand the concepts of abandonment, negligence, and confidentiality, as well as the purpose of a Good Samaritan laws. The certain events that deal with contagious disease, abuse, or illegal acts must be reported to the proper authorities. Remember, your organization typically has policies and procedures established for reporting. Crime scene operations are a complex environment. We must work to preserve the scene while providing adequate care to our patients. And your job is not complete until the paperwork or your documentation is done. And then also understanding the following and following these concepts will help you to be a good EMR. So let's do a little review. Question 1, emergency medical responders have the legal duty to act. A, only when they are being compensated by a certified agency. B, if they witness an emergency scene while not on duty. C, even when outside of their response jurisdiction. Or D, if they are employed by an agency as an EMR. And take a second to read those over. And an emergency medical responder has the legal duty to act when? If they are employed by an agency as an EMR. If you don't have a mothership, then you're protected by the Good Samaritan Act or laws. Number 2, patients are legally able to make decisions regarding their own care if they are A, of legal age according to state law, have injuries that are life-threatening, C, refuse transport to the hospital prior to becoming unresponsive, or D, have bystanders who can verify their competency. Are of legal age according to state law. EMRs have the ethical responsibility to, is it A, provide care only when a paramedic is present, or B, discuss the details of each case with their coworkers and families, or C, transport all patients to the closest hospital, or D, conform to accepted professional standards of conduct. Answer is going to be D, to conform to the accepted professional standards of conduct. All right, so that's it for Chapter 4's lecture. Go back and read Chapter 4 in your textbook. There's a lot more detail in there. And then the next chapter we will be covering is Chapter 5. Thank you very much.